So what we're going to cover today, as you've seen on the information flyer, is we're going to talk about what asthma care needs to be improved, and how to decide which inhaler device is the most appropriate device based on observation of inhaler techniques. So I'm going to start with those two things before I hand over to Michael Crooks. And I thought it would be useful just to remind ourselves what are our aims for asthma control. And I think this is important partly because I think a lot of patients don't have very high expectations of their asthma. And when you ask them about it, they seem to think that they will need to live with a certain amount of symptoms, that asthma is going to restrict them. And they also sort of tend to understand their asthma in terms of an intermittent condition rather than a long-term inflammatory condition. So just to remind ourselves, what we're hoping is that a patient who's well controlled on asthma has no or very few symptoms. And what we mean by that is that they're really not having daytime symptoms, or definitely no more than twice a week, that they don't have any symptoms at night, that they have no restriction on activity, so they're not having to limit their exercise because it brings on their symptoms. And effectively, this means that they're not needing to use their reliever inhaler more than twice a week, which effectively equates to 1 or 2 reliever, or usually salbutamol inhalers a year. And of course, we don't want them to have symptoms, but we also want to reduce their risks. So the risks of having those asthma attacks, the risks of high dose oral steroid courses, and only 4 or 5 oral steroid courses in a lifetime increases long-term condition risks such as cataract and diabetes. And we want to reduce the risk of airway remodeling from chronic uncontrolled asthma. But if we look at what asthma control is like, and this is a slide from Asthma and Lung UK on a survey that they did only a few years ago, and they asked asthma patients what their control was like. It is poor across the board. So the majority of our patients do not have well-controlled asthma. We should be aiming for that, but that is not what the majority of asthma patients have. So, you know, across income groups, people have poor control, but the lower the income group, the higher the chance was that you had uncontrolled asthma. So even in the high income groups, about 1/3 of patients have uncontrolled asthma, but more than half of patients have uncontrolled asthma in the lowest income group. So this is an issue of health inequalities as well. What about asthma outcomes? Well, asthma outcomes in the UK are poor. The UK has some of the worst asthma mortality rates in Europe, about 1.5 times as high as the rest of Europe. Plenty of people still unfortunately dying of asthma, and 90% of these deaths are linked to preventable causes. It's thought that 70% of emergency admissions could have been prevented. So there's a lot that we could be doing better to try and improve asthma outcomes. So why is asthma control poor? Well, it comes down to 2 issues around prescribing. I'm not going to talk about the wider determinants or diagnosis, but just the things that we can do in terms of prescribing. And these are 2 major preventable issues. So patients are not using the right medicine. They're not understanding asthma as an inflammatory condition of the airway lining that requires regular use of your preventer inhaled corticosteroid inhaler to try and reduce that inflammation, to prevent having the bronchospasm that you get when you get triggers. So we would want that to be 100%. 100% of our asthma patients should be using their preventer inhaler regularly. Unfortunately, studies tell us that adherence is something between 15 and 54%. They are though using too much of the reliever inhaler, so the short-acting beta agonist inhaler, usually a blue salbutamol inhaler, and at least 38% of patients are overusing this inhaler to try and control symptoms, but that's doing nothing for the underlying condition. So people aren't getting the right medicine. And the second problem is it's not getting to the right place. So you'll not be surprised to hear that inhaler technique is often poor in asthma. And also that there's very low adherence to spacer devices, which are recommended to be used with pressurized metered dose inhalers. And why is this a problem? Well, we know that if you are overusing your SABA inhaler, then you're more likely to have exacerbations and you have a higher risk of death. You can see that that risk goes up quite significantly once you've had more than 2 short-acting beta-agonist inhalers a year. It just goes up the more inhalers you have. You've got twice the risk of hospital admission or exacerbation if you're using even 3 to 6 inhalers, and that risk just goes up the more you're using. The opposite is true of ICS inhalers. The more regularly you're using these inhalers, the lower your risk of death. So now some of you may have heard of incentives that have been in place to try and reduce the carbon footprint of inhaler prescribing, and you might be wondering what this has to do with asthma care. So I think I just want to outline the case here. So what has the climate and nature crisis got to do with asthma care? Well, firstly, it impacts our asthma patients. So the climate and nature crisis has been found by the WHO to be the greatest health threat to our patients in the 21st century. And it's the reason why 3 years ago, the NHS declared itself its ambition to be a net zero health service. But if we look at what the link is, well, all of those things that are burning fossil fuels that are leading to warmer temperatures are also causing air pollution. Air pollution directly impacts both asthma in terms of causing asthma, but also in terms of worsening asthma, leading to asthma exacerbations. As our climate becomes warmer, we're having longer allergen seasons, which is also impacting on asthma patients. Heat waves tend to lead to more pediatric asthma admissions. Most of the new infectious diseases that are being caused by some, at least partly due to biodiversity loss, are respiratory infections that obviously have a higher impact on our respiratory patients. And then we know that poorly insulated homes, cold and damp housing is linked to worsening asthma. So those are the sort of the reasons we should be we should be trying to tackle the climate crisis. And the pressurized metered dose inhalers, the inhalers that we tend to use in the UK, are 13% of the NHS's carbon footprint related to direct clinical care, and I'll explain why in a minute. They're 25% of the general practices prescribing footprint, and because they're a hotspot, NHS England has a target of 50% reduction in inhaler carbon footprint by 2028. So then if we look at the carbon footprint of inhaler prescribing, we can see that it comes from 2 different areas. It comes from the number of inhalers prescribed and the type of inhaler prescribed. If you look at the chart on the left, it shows you that in the UK, most of the inhalers that we prescribe are reliever inhalers rather than maintenance or preventer inhalers. So that's the chart in the blue. And then if you look across to the chart sort of next to it, you can see that the greenhouse gas emissions are almost exactly mirroring the number of inhalers that we prescribe. So basically what this chart is saying is that if we focus on asthma control, if we focus on people getting the right medicine, which is their preventer inhaled corticosteroid, we can massively reduce the carbon footprint, and that is 70% of the carbon footprint. The other issue of the type of inhaler device prescribed is very much linked to making sure that people get the right medicine to the right place, and I'll explain that later. But basically what this is trying to describe to you is that we can just focus on making sure that we're delivering the right care for our asthma patients, and that should lead to massive reductions in carbon footprint. If we just look at inhaler devices, we can see that the UK is out of step with Europe. So we prescribe a lot of metered dose inhalers. About 70% of our inhalers are metered dose inhalers. That's not the case for the rest of Europe, where it's less than 50%. And in Scandinavian countries, it's less than 20%. And the British Thoracic Society has said that that variation suggests that there will be clinically appropriate ways in which we can reduce the level of metered dose prescribing in the UK. So what are the device choices for asthma? There's basically 2 choices. We can either prescribe dry powdered inhalers or pressurized metered dose inhalers. I've put a few images of the dry powder inhalers that are on our asthma guidance, which Michael and Jennifer will be talking you through later. But the thing that I want to talk about is, how do you make the choice? How do you make the choice with a patient about which is the best for them? And one of the key differences is that a dry powder inhaler requires a quick and deep inhalation that you're taking over 2 to 3 seconds. So it's over 2 to 3 seconds, and it's your breath that is delivering the medicine to the airway. So it's breath actuated. It's a good inhaler if you've got normal inspiratory flow, which will be most patients, and it doesn't need a spacer device. The other advantage, as you can probably just about see from the images, is that all of these come with dose counters. So you can actually track your medicine and when your inhaler might be running out, which can be really handy for patients. Pressurized metered dose inhalers, well, these require a slow and steady inhalation over 3 to 5 seconds as you press down on your canister, or you don't have to coordinate if you're using a spacer device. You can use 5 tidal breaths, or you can use a breath actuated device. They are good for patients who are young or who've got severe disease because they might not have the inspiratory flow to effectively use a dry powdered inhaler. And they sometimes come with a dose counter, but often not. So it can be difficult for patients to know whether the puff coming out is just propellant and no medicine in it, or whether they're throwing away inhalers that actually might have quite a lot of medicine left in them. And what do actually patients prefer if we ask them? So the study on the left is a chart from a study that was done of people who mostly were using pressurized metered dose inhalers, and they were asked, which device would you prefer to use for everyday use? And they were given a huge choice of inhaler devices, and they were trained on how to use the different inhalers. And actually the vast majority of patients chose a type of dry powdered inhaler, even though they were already on a metered dose inhaler. And that study didn't talk about environmental impact at all, but if we were to look at environmental impact and ask patients if they want a choice based on environmental reasons, then actually 60% say they would consider, they would change, or they would consider changing. Another 21% would consider changing their inhaler for environmental reasons, and about 20% saying that that's not a consideration for them. So when we're looking at which device might be the best for the patient, I would really recommend that we get placebo devices. It's important for people to know what these inhalers look like, and be able to choose the type of inhaler device that best suits them, really. So I would very much encourage everyone to make sure that they've got placebo devices with them, as well as training devices. So you can see the image which has got a little whistle. That's a tray inhaler, which is really useful for making sure that a person is using their metered dose inhaler correctly. And then the image at the bottom is an in-check training device, which you can use to work out what someone's inspiratory flow is and whether they're better suited for a dry powdered inhaler or a metered dose inhaler. You can work out which particular inhaler they might be best with, but you can also use it to train people to use the correct inhaler technique. And obviously, I'm also wanting to just push the fact that there are lots of really fantastic inhaler device videos from both Asthma and Lung UK and Right Breathe UK, and we should really be sending patients reminders of this once we've actually trained them on how to use it in the consultation. So how are we going to put all of this together in the consultation in terms of making sure that people are getting the right medicine and it's getting to the right place? I just wanted to alert you there are lots of resources that are going to be available on a website that we've put together, and I'll show you that later. But really, when we're having a conversation with our patients, it should be a conversation rather than a tick box. We should be trying to understand how their asthma is affecting them, whether they know what to do when their asthma is getting worse, and how often they're using their inhalers. Don't just rely on your ACT score. Make sure that you're looking to see how many preventer and rescue inhalers have been prescribed over the last 12 months. And that will give you an idea whether actually there is objective ICS or preventer underuse and SABA over-reliance or overuse. And then we really should make sure that at every opportunity we're making sure that patients understand that asthma is an inflammatory condition, using an asthma airways diagram to help them understand that there's swelling of that lining and that really that's why they need to use their preventer inhaler. We should be talking through, obviously we're all familiar with the personalised asthma action plan, but perhaps also thinking about air quality, housing, breathing techniques to help people control their asthma. And then we also want to think about specifically looking at what's going to help people remember to take their preventer inhaler. Is it just about creating tiny habits? Do they have particular concerns about the steroid in their ICS that we need to address? And would they benefit from just using one inhaler that contains both the preventer and rescue medication? This is something that Michael Crooks is going to talk to you about in the next section. And I think the conversation about which inhaler is best should start with the question of how they're using their inhaler in the first place. And the thing that we would really like to encourage is that we observe people's inhaler technique. There isn't any correlation between whether people tell you that they can use an inhaler and their actual inhaler technique. So we're not going to know unless we're actually observing it. And if they're using a pressure meter dose inhaler, we can then see, are they using an incorrect technique? Are they taking a quick and deep breath with their metered dose inhaler? Are they using a spacer device? If they're not using a spacer device and they're taking a quick and deep breath, it's a clinical decision then to consider whether a dry powder inhaler might suit them better. If they also don't know when their inhaler is empty, they might be better off with a dry powdered inhaler, and then we can talk about whether or not they can use their dry powder inhaler effectively, look at placebo devices, look at those inhaler training devices, perhaps offer them a dry powder inhaler and make sure we review them. If they're using their metered dose inhaler correctly, and they know when their inhaler is empty, then the question is, are they interested in the choice of a more environmentally friendly inhaler? It's only a choice at the point that they're using their inhaler correctly. And then we go through either encouraging them to use their metered dose inhaler correctly or looking at whether they can use a dry powdered inhaler correctly. So those, this is a visual chart that's available. Those two images are actually one whole chart that you can print out that can help you in the consultation. So now I'm going to hand over to Mike and Jen.